All right, Tyler. Thank you so much for being with us tonight. I really appreciate that you reached out to us. We're always flattered when great DOs reach out to us and offer to be on our podcast.
Well, thank you for having me. I think it's a great podcast. I enjoy listening to it and happy to be able to share more information about osteopathic medicine and what I've experienced with it.
Tyler, can you start by, there's so much that I want to talk about tonight, but can you start by telling us about the new school that you're working on and what you're actively involved in at this point in time?
So right now it is a proposed new school. I live in Baltimore, Maryland, and we are working on developing a common combination or in partnership with Morgan State University. Morgan State University is an HBCU, a historically Black college and university. And we have a partnership with them where we're developing an osteopathic medical school on the campus of, but independent from the university there. So we're just getting started. We've got another 2 years of work to do, but we will be building a new school in Baltimore, Maryland to help train underrepresented minorities, bring diversity into the osteopathic profession, enhance our teaching of population health, and just expand the possibility of what osteopathic medicine can do.
It sounds awesome. And is this the same project we spoke to Barbara Ross Lee about a year ago? Is this the same project that she was talking about?
She is my boss. I just left her. She is terrific. She is a visionary, and she's actually an excellent manager who knows where she wants people to go and gives you the ability to get there along with her. So yes, it is the same project.
That's amazing. And go ahead,
I was
please.
just going to say, we're calling it MDCOM as a proposed com, which has a little bit of irony, but the MD is Maryland, and it will be a College of Osteopathic Medicine in Maryland.
And last year when we spoke to Barbara Ross Lee, and we had a couple of African-American leaders in the osteopathic profession, I definitely recommend that anyone listening to this episode that hasn't heard those, go back and listen. But we talked about promoting diversity in osteopathic schools. So is that the main mission of the school?
The mission is to train diverse physicians, and I would just reinforce that diversity is a two-way street. It does require multiple different types of people with different backgrounds to train together and to develop the culture of the school and to affect and educate others in the profession on diverse cultures.
That's awesome. Tyler, another question that I have for you. We spoke earlier about your work with AACOM. So before we kind of go back to how you started, can you tell us a little bit about the time that you spent with AACOM and all of the really interesting and important projects that you worked on while you were there?
Sure. Well, I worked for AACOM for about 14 years, basically doing clinical education. And I started in 2008 when there were 28 osteopathic medical schools, less than half than there are today. But with 28 schools, when I started, only 6 of our colleges did assessment after rotations. So a minority oversaw and monitored our students as they were going through education. And my role was to standardize education, to create a standard curriculum in osteopathic manipulative medicine, to develop the core competency framework for osteopathic medical education, which means putting in writing what you need to learn to be a DO. So we've heard about the 6 core competencies or 7 core competencies. That's something that we worked on at AACOM so that it means the same thing when you say you're a DO. One of the issues that they brought to me early on was if you took the boards as a DO, they'll have questions about what do you do if you do the Chicago roll and what the problem is and what's the Kirksville crunch. And that gave a benefit or an advantage to students training in Chicago or in Kirksville. And that really was something we wanted to work on so that there is a body of knowledge that was shared across the profession, across the country, and actually even across professions so that MDs, PAs, chiropractors should be using the same words. And you don't get the secret word because you go to a certain school, but it's the same language. So we put together the glossary of osteopathic terminology, installed that as the common language for the profession. We worked to install our language in SNOMED, which is the electronic medical record, so that when you document that you did a TART exam, you will get paid for 4 body parts. And just the clicks that we used to do for osteopathic medicine used to not count. And I also worked on policy, like the policy saying that every osteopathic medical school needs to have at least one rotation where GME occurs. Because when I started, you didn't have to have that. You could train in all community-based hospitals, but that disadvantaged you in trying to find residencies. So that was one policy we worked on quite a bit. Another policy was a difference between DOs and MDs, whereas DOs in osteopathic manipulative medicine training and other training partner up with other students, assume the role of patient, which provides them with an empathetic understanding of what patients go through, forces them to be poked and prodded like patients, and gives them a different perspective of an interaction in a healthcare environment. The AMA said that this was unethical because you were forcing students to reveal more than they wanted to. And if you acted as a patient, things may be found out about you that you don't want to have found out. We felt this was integral to our education, and we worked with CJA, the Council for Ethical and Judicial Affairs, to make sure that they understood that while this was exposing yourself to other students, we felt it was a necessary part of professional identity formation, that as you become a doctor, you understand what it feels like to be on the other side of the stethoscope and the other side of the exam table. Just a few other things I'll throw in there because they were big is the military relationship. It was actually the first thing I was given to take on. And I worked to increase the DO representation in the military because in 2008, it was between 5 and 10% of doctors in the military were DOs. But we were able to show the military that DOs stayed longer, were a good investment, and we were able to take the Army from 5% to 50%. At the time, the idea was to get DOs into military residencies because we didn't have enough osteopathic residencies. And in 2008, that was the year we did away with the osteopathic rotating internship and only had 50% of the residencies we needed for all of our graduates. So our graduates were forced to go into ACGME residencies, which were different than DO residencies. So those are some of the big things. Last thing I'll throw in there is we started NAOME, the National Academy of Osteopathic Medical Educators. And that's something that Linda Hoyne put a lot of work into. The idea was to create a Ivy League class of osteopathic physicians. And while NAOME is not a fellowship, there's no body of knowledge. It did say to people that they were leaders in the profession and those that we felt had done extra and really earned our respect and should be looked up to. So we tried to separate out our educators so people understood what it took to become a leader and what the requirements were to be there. That, in a nutshell, that's the last 14 years of my life.
Tyler, that's amazing, and an amazing amount of work. I think students today, myself included, don't realize how much went on behind the scenes to sort of get osteopathic medical education to where it is today.
It's actually kind of funny because we, as DOs, aren't sure what we want to be, and it changes frequently. The standardization of curriculum for OMM was a committee that met for 29 years before I took it over. And every couple of years, there was a change in the mission or what they were asked to do. And my job was to develop a process, a timeline, and to hold people to it. And if the ask changed, we were still going to publish a standardized curriculum because that's what I had promised people. And we took 3 years after that. So it was a total of 32 years the committee met until we finally published a standardized curriculum for OMM.
Tyler, what are your thoughts on the ACGME merger that occurred a few years ago?
The ACGME merger is an interesting aspect of our history, similar to what happened in California in the 1960s. I think we saw that the two professions are moving closer together. There were questions as to what we were doing. And I think it was important to unite and have a single standard for each field. But it's also important for us to list and document what it is we're providing students that's better than or different than MDs. So I think we haven't come out of it well yet, but there is still potential. I think if you have skills that you get as a DO, you should be credentialed for them, and we should be able to stand behind the product we produce so that if we say we're graduating a student who is skilled at history and physical taking, that it be the same as an MD who does history and physical taking, but that if we say you can do a musculoskeletal exam better than, then we should say, here's what you have to do. Here are the core competencies that differentiate you. And we didn't do that yet. I'll tell you, we had an osteopathic recognition committee, which was charged with saying what the difference was. And they met for a number of years and did not come up with an answer. So I don't think we've come out of it with a clear view of where we're going. And I think there's a lot of disorientation in the profession right now and a need for a redirection and a re-energizing of the profession based on the strengths and what it is that DOs have that matter.
I appreciate that, Tyler. And I think that's part of, in a small part, what we're trying to do with the podcast is highlight what we do that's special. And I think the episodes week after week show that. So I appreciate that answer.
Absolutely. And a lot of the leadership does come from below. People do what they feel they should be doing. And then those become examples that get brought up nationally and hopefully highlighted and promoted so that others can take on the mantle. But also, policy matters. And if we tell every DO school they have to do a specific thing, then we should say, yes, they're doing it. Every DO school has between 150 and 250 hours of OMM. All DO schools have a minimum of 8 weeks outside of a hospital so that you're learning to practice medicine without 20 other physicians in training. There's a discomfort in that makes you uncomfortable in training that will make you comfortable when you go into practice. So there are things that are unique to osteopathic medicine that I do think it's important to promote, and that people should know that the reason they're uncomfortable is it will have a good outcome in the future.
Tyler, we're going to take a step back now. And can you tell us a little bit about where you grew up and when you became interested in medicine and where you went to college?
So I'm a bit of a nomad, or we call it peripatetic, where you spend different times in different areas. But I was born in Long Island, South Shore of Long Island, America. When I was 10, we moved to Israel, and I did my elementary school in Israel, graduated from the Sefer Yesodei Arzim, then moved to South Florida, North Miami Beach, and Hollywood, Florida. Went to college at Emory University, got degrees in psychology, anthropology, and Hebrew language. Went to Nova Southeastern for medical school. And after medical school, I decided I liked research, and I was the second DO to do a research fellowship. I did that at Midwestern University, at the time was Chicago College of Osteopathic Medicine. After that, I actually had an offer from Chicago College to teach, and I did something very stupid. I applied to one residency program and said, if I get in, I'll do a residency. If not, I'll do the practice pathway and go into practice like the DOs of the day were doing. Went to Yale to interview, and they said, well, they just want to see what DOs were. They weren't sure they were going to take me. But at the time, the match was revealed through a newspaper ad taken in USA Today. So match day, you had to go find a newspaper to see if your number was there, to see if you had matched, because this was pre-internet. I actually ended up matching at Yale, did 3 years of internal medicine there, liked academics, decided I wanted to teach for a living. I expanded my number of jobs I applied for. I applied for 2 jobs, and it was either going to be going to Johns Hopkins in Baltimore or Harvard, starting their Salem branch. Chose to come to Baltimore. Taught at the Sinai Hopkins program in general internal medicine for 18 years, and got involved in academics. Started off with musculoskeletal medicine research, I was actually put in charge of the business of medicine curriculum at Hopkins and did the outpatient care, which was considered the least important portion of Johns Hopkins because it wasn't in the John, it was outside in the community. But with managed care, business of medicine became much more important, and outpatient medicine became the feeder. Got involved with the postal anthrax attack of 2001 when 3 patients came to my office trying to die. Didn't know what they had, threw everything at them to keep them alive. Learned a lot about policy, and that diverted my practice away from fibromyalgia, which, while exciting academically, was a tough field to be working in. And I moved on to disaster medicine from there and did policy and did global health. The policy took me towards an interest in what I could do to develop myself. I was looking at moving from full practice to policy of medicine, applied to a whole bunch of fellowships, the White House Fellowship, Robert Wood Johnson, and Steve Shannon said, "Why are you doing it in training? Why not do it for real?" And asked me to come to AACOM as the first DO focusing on medical education full time. There were DOs in administration, but none actually doing the nuts and bolts of curriculum and assessment. So he asked me to work with the military, work on test validity and reliability, work on assessment issues, and test construct, test criterion, test content. And I got involved in policy for 14 years, worked at AACOM. During the COVID pandemic, I took a major shift. I actually ended up taking care of COVID patients early on and worked at the Baltimore Convention Center Field Hospital. I was the medical director there. We built a 252-bed field hospital on the floor of the Baltimore Convention Center to house and care for people with COVID. This was early on in the pandemic when the hospitals were overwhelmed. And now moved on to MDCOM, the proposed college in Baltimore. So that's the quick and dirty.
Oh, yeah, holy moly. That's like going down a whitewater rapid venture, right? But I'm gonna go back and just ask that's an amazing story. That's a ton in like 15 minutes. But if you don't mind, I'm just gonna ask you a couple of specific questions about points along your journey. So my first question is, so you grew up on Long Island, you went to Israel, then you end up in South Florida, and obviously Nova Southeastern is in South Florida. But can you tell me, how did you end up, and obviously you're a DO leader at this point. How did you first find out about osteopathic school, and how did you choose Nova Southeastern as a place that you wanted to go to school?
So I had a hard time choosing between DO and MD. I have 3 chiropractors in my family who are very influential. We are earthy, crunchy granola in nature, with an alternative medicine and spiritual bent. So that drove me towards osteopathic medicine. But when I was in college, I was looking for what could I do where I would be loved? Where can I go to work and help make people's lives easier and more comfortable to where they would feel good about me and I would have value in what I did? So I thought about being a college professor. I thought about social work. Of course, coming from a Jewish family, being a doctor is always in the mix. At Emory, they didn't know anything about osteopathic medicine at the time. They knew chiropractic medicine was not something I should consider. And as a college graduate, they thought social work didn't have the prestige or the options available. So when I looked at MD and DO, I applied to both, got accepted to both, and wanted to go DO, but was scared. I didn't know if I wanted to join a minority group, that I'd have to explain myself. I'd rather explain myself from a position of power. So I actually started off at Northwestern University in Chicago. They put me in the 6-year program after my 3rd year of college, and I did my anatomy there, liked it, but didn't feel comfortable. I've got a little bit of the oppositional defiant disorder in me, where conventional isn't always the best, and finding the problems is more fun than playing with the solutions that are accepted. So I did switch to Southeastern, from Northwestern to Southeastern, which was right by my house, and I was able to live at home for the first 2 years of medical school. which was also very helpful. Um, and that's how I ended up at Nova Southeastern.
All right, Tyler. That's so you went from Nova Southeastern and then you're throwing around very lightly, and I appreciate that, places like Harvard, Yale, Hopkins, so these are places that to any physician, when I always I'm a little nerdy, so when I talk to my wife, I call it like the Disneyland or these are like the places that you want to visit as a doctor. These are like the ivory towers of medicine. So how was it as a DO? Again, you started at Emory, which is very prestigious, not taking anything away from Nova Southeastern. I'm very proud of my medical school, but you went from maybe a less known medical school, and then you're looking at these big institutions. Can you talk to us a little bit about what it was like going to those places with your training from osteopathic school and how you were received at those places?
So always fun stories. I do think it's important to spend some time in an ivory tower like Yale, Harvard, Hopkins, because what you learn is that there's no difference in what you're learning. The difference is in the peer group and the resources available. But you learn that your knowledge is deeper and stronger once you've practiced it. And the training we get in the DO school in community hospitals, where you're one-on-one with an attending or where you're seeing the patient first, really gives you good training. So I trained at Nova Southeastern. I looked at going to Suncoast Hospital in Largo, Florida, which was my number one choice, but they told me I didn't have a chance of getting in. I looked at going to New Jersey, and I rotated in New Jersey and Oklahoma, in Michigan, and other of the top programs in the osteopathic profession at the time. And I decided to do a research fellowship because if you want to go to one of the ivory towers, the coin of the realm is research. It's what have you published? It's what have you become a leader in? And when we look in academics, we always ask, what's your area of the world? If you were to give a talk, what would you talk about? What do you know more about than anybody else? What is special about you? And that's something that I think Yale did better than the DO world, because in the DO world, we want to be the best at everything. And you can't be the best at everything. You have to focus down and know what it is that your skill is and what it is that you would give a talk about if you're asked to give a talk, what it is that you're going to read about as soon as it comes out, what excites you. And when I trained in my research fellowship at Chicago Osteopathic, I looked at the use of OMM in asthma, which gave me two fields, because OMM no one knew about outside of the osteopathic profession, and asthma was a good disease. I got to Yale and I had done a year of internship. So I had gone further than everyone else. And as soon as I started, people knew I knew what I was doing because I had already done it. Not everybody. I had one attending, actually a Nobel Prize nominee multiple times, world renowned, but hadn't practiced in probably 4,000 years. And he's our attending, and I'm the resident. He's going, do whatever you do, just tell me when you're in trouble. At the end of the rotation, he's supposed to give me feedback, and I knew he had no clue as to what he was talking about. But what he did say was pretty nice. He said, I was reluctant to having a DO here, and I told him that they shouldn't take you, they shouldn't have you here, but you did okay. No one got hurt. Can you tell me what your training was like? And I said, sure. DO schools are correspondence schools, and after 6 months of doing correspondence work every day, I went to a hospital for 4 weeks and they gave me a DO degree. He goes, what? Yeah, it was, those letters were thick. You didn't go to medical school? I said, no, it's a DO school, it's correspondence. And he charged up, went to the chair of medicine and started complaining about me, saying he didn't go to medical school. So I got called up to the chairman's office and said, don't play with the professors. They're special, we keep them around for a reason. They don't have to know how to take care of people. But I also had problems where, first I started my internship and I wrote an order for an x-ray and they said, DOs can't write for x-rays. And I said, yeah, I'm an intern here. I have to write for an x-ray. I need an x-ray. They said, just make it illegible. I'm not going to make it illegible. I'm going to fight the battle now before things get going and I have to pretend I'm something I'm not. So they wouldn't give me the x-ray. So I went and took the portable x-ray machine and called my cousin, who was a chiropractor, and said, what do I do for an x-ray? He gave me all the chiropractic advice, which I learned quickly that chiropractic x-rays are weight bearing and medical x-rays are not. Our x-rays are anatomic. They use much more radiation than we would use in our field, but I got the x-ray and I could tell whether it was failure or not. But sometimes you learn the hard way. So
So
there were some
some
challenges,
hiccups. Yeah.
some hiccups, but fun ones.
So tell me, my next question is, you talked about doing one thing well, but you sound like you do everything. So you've done clinical medicine, you've done research, you've done policy, and then it sounds like during the pandemic, you went back to clinical medicine again, and now you're back to starting a medical school. So you've worn all of these hats. Is there one that you like more than the other? And has it been hard to sort of step in and out of these different roles?
So I am an academic physician. I love teaching students. I love knowledge. And I like being in an environment where people are developing and discovering themselves. When I'm a practitioner, I'm still an academic physician, even though I'm not doing what I love and what I want to do entirely. But at least I know how I define myself and what I want to get to. I love being in an osteopathic medical school. I love having other smart people. I like feeling supported. So I do think it's important to define yourself and to define yourself somewhere you're comfortable. When I talk to students, it's always what gets you excited? What gets you staying up? What gets you staying late? What gets you forgetting what time it is so you're doing what you feel really has value and makes you feel happy? So for me, it's academics. For me, it's writing papers. It's discovering knowledge. It's pushing the boundaries of what we know so that we can know more and challenging ourselves to do better. I feel comfortable being uncomfortable in my knowledge and pushing what we learn, but by using data and standing on data to make educated guesses, and not just random guesses, but I can justify it. So those are my word puzzles, my life puzzles that really give me the ability to practice in a way that I feel comfortable.
That's awesome. Again, great answer. Thank you for that. The next question that I have, again, I'm just sort of going through the rapids of the story that you told, is about the military. So, we had a lot of podcast members last year that were military DOs that were in school on military scholarship and pursuing military careers. Mike, and I don't know much about it. So what I do know is, and again, please correct me if I'm wrong, is that during World War II, that's when a lot of opportunity started for DOs because we were not in the military. And you spoke about a progression of DOs to becoming 50% of the military under your guidance. Can you talk to us a little bit about that progression and why that happened and why you think it's so important?
Absolutely, because the military medical complex is tremendous. They do great research. They train students in management, in leadership, in population health, in prevention, and they do a better job than other residencies and a better job than most medical schools in addressing a lot of the expanded skills that physicians need in the new environment. So military physicians are sought after. When I started at AACOM in 2008, the military medical complex was the same size as the osteopathic medical profession. They had the same number of beds in hospitals, but they didn't have students. So we coveted their research, we coveted their hospitals, and I looked for a way in. I started with the Joining Forces program, which was looking at helping people who separated from the military adjust to civilian life. It looked at how we can partner together to help use civilian resources for the military, because while they're tremendous at teaching leadership, they don't have many kids in the military, and their OB is not as strong as other areas because they don't have the same numbers. So they needed the civilian complex to help train students who are in military residencies. And the osteopathic residencies were interested in getting military residents. So that's what started the relationship. I was looking at, we were growing to 20, from 28 medical schools. Over the next, for 20 years, we had at least one new medical school a year without GME for these students to graduate into. So I was looking at their hospitals as potential training grounds for GME and for our undergraduate students. The program that we hooked onto is called the HPSP program, the Health Professions Scholarship Program, which pays for medical school in its entirety, gives you a stipend, trains you in leadership, physical education, and other things during medical school. So you lose your summer vacation, you have leadership training, you have officer training that happens. And these are skills that we wanted to bring to the DO medical schools. So that was a big part of what we were doing. And right now, when I started in 2008, there were about 400 HPSP scholars in the Army, about 120 in the Navy. Air Force had about 100. We're still only about 15 to 20% of the Air Force and the Navy. But out of the 400, we went to 50% of those scholarships went to those schools. So there were about 200 a year, up from 15 to 20.
It's amazing. Very cool.
Policy matters. And those things
Absolutely.
can happen on a large scale.
Tyler, getting back to the beginning, coming full circle, if we have some students that are some pre-medical students that are listening that are minority, that are interested in the new school that you're working on, what is the projection for when it would be open? Do you have an idea?
So it generally takes about 2 years to start a school. I've been on board for about 2 months now. We are getting things together. My advice to students who are underrepresented minorities, students who are first generation college graduates, is to look at life as a long picture. Figure out what you want to do, figure out what makes you happy. Medicine is not unattainable. It is not that hard. It's just a whole lot of it. So buckle up, get ready, explore, prepare, and there will be spots for you. Most people don't realize this, but about 20% of DO students come from pathway programs within the individual colleges. Those are post-bac programs, master's programs attached to osteopathic medical schools and to universities. For people who have not known doctors or not known people in medicine, get closer to your medical schools. Look at the post-bac programs, look at the pathway programs. And while it takes a long time, you're going to be the same age in 10 years, whether you go to medical school or don't go to medical school. And if you plan your life, and I used to work with the residents, to plan their lives in 3 phases, because you can't tell a student no in terms of going to medical school, or they're going to pursue what they think they should be pursuing, what they were told to pursue, and they're going to destroy their life to succeed at a life that they were told they wanted for 7 to 10 years. And this is work that Larry Silverman did on the natural cycle of professionals. So 7 to 10 years after you graduate from medical school, you're going to kill yourself. You're going to do everything. You're going to think you can be an expert in everything. Then you realize that you need to focus down on what makes you happy and what you have time to do. And that takes another 10 to 15 years. And then you start saying, what am I good at? And you finally mature and say, I'm going to specialize in these patients, or I'm attracting the patients that I show the most interest in. So I'm getting a lot of the irritable bowel patients because they know I spend time with them. And that happens about 20 years into your career. And your waiting room explodes with similar types of patients just based on what you project and what you share. So there's a lot of different options in healthcare. It is all attainable. It is all understandable. If you've taken organic chemistry and gotten a B, then you can memorize anything and put it together in strange ways to create molecules that don't exist and will never exist, but you understand could exist. If you can do that, you're smart enough and you will be able to do it. One of the things I learned at AACOM, 48% of medical students get into exactly one medical school and they go. They look back, they question themselves, but almost half don't have any choices. What it's important to know is that if you are smart enough, it doesn't need to happen in 4 years. It's okay to take a gap year. We know that if you got a 495 on the MCAT, the chance of you getting through in 4 years is about 95%. Below that, it goes down to 50%. If you've got what it takes and you're going to take the time to do it, you can do it. One of the things I'm learning in the underrepresented minority community is there is a resilience there. There is a strength there, which is different than other people. They don't look at the same timetables. We see a lot of people taking a year off, taking 5 years to go through college, whether it's because they have to work during college or they have other challenges. There's less of a stigma of, I've got to get through in 4 years. But then when you apply, that stigma comes into play that you didn't have going into it. So if you have a different path coming in, but then you're expected to fit into the cookie cutter hole that was created for other people, it's not going to work. We have to understand that working at an HBCU, 5 years is normal. Working during college is normal. Having family that's part of your journey is part of what happens at a lot of colleges in America. So I guess I would tell people, pursue your goal, talk to people who know what they're talking about to make sure it's attainable. But if it's attainable, it doesn't have to be today or tomorrow, but you can get there.
That's inspiring and great. Thank you very much. So our last, our sort of grand finale question, Tyler, is can you give us one piece of advice that you were given from someone else in medical school, in high school, during your research at Yale, at Harvard, anywhere, anyone, that really you feel was inspiring and helpful to you and that you would pass on to our listeners?
I guess I will share the advice of my friend, Dr. Robert Crook, who told me a real friend won't tell you you're great. A real friend will tell you when you've messed up. And it's important to have real friends who are honest with you and will support you as well as reflect on what you're doing and what you need to do. So we live in a time when inspiring people can inspire strangers on Twitter and Facebook and tell you you're good enough, you're strong enough, keep going. But that's not a real friend. And that's not what you need to get ahead. Find your anchor, find people who are going to be honest with you, who will help you develop, help you figure out where your strengths are and where your weaknesses are. The best resident is not someone who tells you you did a good job, but tells you what you need to read and where your weaknesses are, because that takes a lot more focus and a lot more bravery. So invite feedback, invite assessment, and find your friends who are going to be with you when you're a great friend, when you're not a great friend, but you have a longer term view, and share life with people over the long term, because it's a lot more fun that way.
Tyler, thank you so much for spending time with us tonight. This was a great session. I really appreciate it, and I'm sure our listeners will as well.
Thank you for the opportunity.